Dr. Ismaili will now introduce us to cell surface protein inhibitors as treatments for eyelid and orbital malignancies.
Yes, thank you very much for Rich and Jeremiah for inviting me. I am going to talk about PD-1 inhibitors for specific to periocular lesions. I don't have any financial disclosures relevant to this presentation. So let's talk about immunotherapy in general. I think the older strategies you have heard about for cancer therapy, interferons, interleukins, vaccines even, have been used for cancer therapy. Those are sort of the older strategies, and I think what has perhaps revolutionized cancer therapy in the last almost 10 years is the use of immune checkpoint inhibitors. So these are classes, this terminology immune checkpoint inhibitors really refers to two different types of drugs. One class is the anti-CTLA-4, and the second one is PD-1, PD-L1. And I've been asked to talk specifically about PD-1, PD-L1 inhibitors. These are drugs that are currently FDA approved. There are multiple drugs that are currently FDA approved. I'm going to mostly show you practical clinical cases, but just this one slide on how these drugs work. PD-L1 is a protein that is expressed on tumor cells, whereas PD-1 is expressed on T cells. And the interaction between PD-1 and PD-L1 essentially keeps the host response in check. So in a way, you can think of it, it does not allow the patient to have an appropriate immune reaction to the cancer cells. So by using anti-PD-1 therapy strategies, we are causing almost an autoimmune reaction against the cancer cells. So this is a very primitive way of understanding how these drugs work. The first FDA-approved drug in this class was ipilimumab. That's an anti-CTLA-4 drug. That was in 2011. It was approved for melanoma, metastatic cutaneous melanoma use. And since then, there has been a proliferation of drugs, mostly in anti-PD-1 and PD-L1 class. And these are the drugs that are most exciting. They have really improved the prognosis for not just for melanoma patients, that now they're being used in combination with chemotherapy or as single agent for treatment of head and neck squamous cell carcinomas, Merkel cell carcinoma, lung cancer, and the list goes on and on. So in 2018, the Nobel Prize for Medicine and Physiology was given to two individuals, Dr. Jim Allison, that I have the pleasure of working with at the same institution at MD Anderson Cancer Center. He is our chairman of immunology, and Dr. Honjo at Kyoto University, and this was specifically for their discovery of immune checkpoint inhibitors. In the words of the Nobel Prize Committee, for their discovery of cancer therapy by inhibition of negative immune regulation. So what about periocular region? So I think specific to the periocular region, the diseases that we can think of as being targets for this strategy are, again, melanomas, cutaneous melanomas, conjunctival melanomas, Merkel cell carcinoma, and squamous cell carcinoma. So I'm going to just show you some cases and kind of focus now on indications that are relevant to the periocular region. For periocular melanomas, first and foremost, it does not work for uveal melanoma, unfortunately. So let's sort of set that aside. But for oculoplastic surgeons, of relevance is we are seeing impressive clinical responses for patients with metastatic cutaneous melanoma. These could be periocular metastatic melanomas, and specifically conjunctival and eyelid melanomas that are metastatic or might have a positive sentinel lymph node. In fact, someone who has a conjunctival or eyelid melanoma with early metastasis in the sentinel lymph nodes would be a really great candidate for this class of drugs. Cutaneous melanomas metastatic to the orbit could be a very good choice for using these drugs. Locally advanced conjunctival melanomas can be considered for this class of drugs. And then now I'm going to just take a moment to show you about 7 or 8 patients just to kind of outline further what patient selection and what might be appropriate. for these drugs. So this is a 72-year-old man, one of our earlier patients treated with PD-1 therapy. He presented with diplopia, proptosis, abduction deficit, had some orbital pain. An orbital biopsy had already been done by the referring physician, and it showed melanoma of unknown primary. This is the appearance on MRI of the residual mass in his orbit. On further questioning, although he was not aware, he had a cutaneous melanoma on his scalp. So this was a cutaneous melanoma metastatic to the orbit. So look at his course after treatment with nivolumab that was given to him every 2 weeks. This is a PD-1 drug, PD-1 inhibitor drug. And you can see the course after 2 months. We actually see a bit of an immune flare. This may be the time point where the patient might actually say that the pain is worse because they have worse inflammation. This is the autoimmune response, if you will. This happens in about 20% of the cases. You get an actual immune flare. And then after 16 months of treatment, you can see that it's almost completely gone. Now, I have a lot of MRIs in between because these patients are being followed carefully. So he was treated for 24 months, after which he was taken off medication, and he remains with no evidence of disease. Patient 2, this is a patient with a large, thick, desmoplastic melanoma, which is a high-risk melanoma. This was in the forehead area. He had appropriate surgery for this melanoma, but PET was negative, but just before surgery, he had an ultrasound that showed a positive lymph node. So due to some comorbidities he had, we elected not to take him back to surgery for lymph node metastasis, and he was treated with pembrolizumab. This is another PD-1 inhibitor. You can see the course of nodal metastasis and resolution over 5 months. He developed one of the side effects of immune checkpoint immunotherapy, pancreatitis. So he was taken off treatment after 5 months, and he remains off treatment. We have 24 months of follow-up, and he has no recurrence of his nodal metastasis. Patient 3, this is a patient that has been heavily treated with surgery, radiation. This is a recurrent cutaneous melanoma in the orbit. He received 2 years of treatment with pembro, and he achieved near complete response. He was disease-free off treatment and died of unrelated causes. Again, these are, I'm showing you these specific cases just to give you the sort of the type of tumors that you may want to select for this type of drug therapy. This was one of our earlier patients. This was a patient with a metastatic conjunctival melanoma. She had metastasis in skin, lung, clavicle, various sites in her body, and no local recurrence. She was treated with nivolumab, and she achieved clinical response, complete response 3.5 months after 3.5 months of treatment, and remains disease-free. So a lot of these patients have been reported already, and you can find them in small case series that have been published. Another good case of a metastatic melanoma in the lateral rectus, posterior orbit, causing visual deficit as well as motility restriction. This patient was treated with anti-PD-1 therapy with complete resolution of his mass. He also got some palliative radiation. So there are some short case series, unique, just specific to periocular region that you can read more on. But what about using this, as Alon mentioned, what about using this for locally advanced conjunctival melanomas that otherwise would get exenteration? This is just an N of one, my case, but I know that others have cases like this. This is a conjunctival melanoma that involves much of the upper and lower eyelid and ocular surface. A patient like this would normally have an orbital exenteration to achieve control, local control, but she was treated with, she's otherwise healthy, she's only 50-something years old. She was treated with nivolumab, which is a PD-1 inhibitor, and you can see the progress over time. After 12 months of treatment, there's only very little pigmentation left. I did biopsy all of these residual pigmented areas, and it was just pigment-laden macrophages, no melanoma remaining. So, of course, she's going to be followed very carefully over time for recurrence. What about squamous cell carcinoma? That's the other disease that definitely we have seen some efficacy for PD-1 inhibitors. You can use this for locally advanced cutaneous squamous cell carcinomas. This is the FDA-approved indication for cemiplimab specifically, but it is expected that all PD-1 inhibitors would have efficacy for the same. And this would be good for patients that you are considering orbital exenteration for example, the T4 tumors that have orbital invasion, or large tumors in the periocular region that surgery would be disfiguring. And other indication might be a patient that has a recurrent squamous cell carcinoma with perineural invasion that there are no curable surgery for, or someone with nodal metastasis. So let's look at some cases. These are old cases. These were patients that were on trials. 72-year-old man with heavily treated surgically with radiation and surgery and radiation, but has massive perineural invasion. You can see the cranial neuropathies, multiple cranial neuropathies. So he enrolled in a PD-1 inhibitor drug. You can see his degree of perineural invasions in the cavernous sinus and in the area of the supraorbital nerve. And he was just treated with cemiplimab, no radiation, every 3 weeks, and you can see resolution of his perineural invasion. So a lot of these patients were treated on trial that then led to a publication in New England Journal of Medicine, and overall response rate is reported as 50% for these very heavily previously treated locally advanced squamous cell carcinomas. And with that, of course, the FDA approval, and now a newer indication for cemiplimab. This is a clinical trial that is available at MD Anderson, and I think now is going to be open at other sites. For these locally advanced cutaneous squamous cell carcinomas, they only get 2 doses of cemiplimab, and then they go on to surgery. You can see the resolution of this lesion just after 2 doses. And then surgery is done for histologic evaluation, and lo and behold, there is complete response of squamous cell carcinoma. This patient only had some squamous cell carcinoma in situ remaining at one edge. And a recent abstract was presented at European Society of Medical Oncology in Barcelona, and out of 20 patients that were enrolled in this trial, 55% achieved complete response, that complete histologic response. And many of these patients were able to avoid the planned post-op radiation, which is important for head and neck cancer. What about other periocular cancers? I think T4 conjunctival squamous cell carcinomas would be probably good for this, but I have to say, despite the fact that we have demonstrated PD-1 expression for conjunctival squamous cell carcinomas, I have not been able to see a clinical response yet. I have tried it in a few patients with orbital invasion of conjunctival squamous cell carcinoma, and I'm not aware of any publications on that. Similarly, for sebaceous carcinomas, we have demonstrated high PD-1, PD-L1 expression, but I have not personally seen any responses, although we have tried. For metastatic sebaceous carcinoma, I'm aware of 1 case report with good response for a patient with metastatic sebaceous carcinoma, and this may have to do with the tumor mutational burden. Sebaceous carcinoma really has a very small mutational numbers, as has been shown in several studies. Side effect profile is important to cover. So essentially any itis is possible. Any type of autoimmune inflammatory response is possible to experience. Pruritus, pancreatitis, hepatitis, colitis is very common. So diarrhea can be a very common symptom reported by patients. And thyroid dysfunction. So these side effects are usually mitigated with the use of steroids, but they're important to be aware of. And ocular side effects have been reported. Uveitis is less common with PD-1 inhibition. It was much more common with ipilimumab. Extraocular muscle enlargement, sort of thyroid eye disease-like inflammatory syndrome is possible. Optic neuritis has been reported. These are, again, usually controlled with steroids and discontinuation of drug or drug holidays. So in conclusion, immune checkpoint inhibitor therapy, and specifically PD-1 inhibitor therapy, is promising. The results are impressive for metastatic and locally advanced eyelid conjunctival or orbital melanoma, and for periorbital squamous cell carcinomas that are locally advanced. And I think these can improve prognosis, but also decrease morbidity from massive surgery. Anti-PD-1 immunotherapy is also effective for Merkel cell carcinoma that is metastatic. And neoadjuvant use of these immunologic drugs in combination with surgery likely are going to be the future direction for this class of drugs. Thank you.